Hello, my name is Shiv Kumarie Santram. Today I'm presenting the final sustainable plan for my tertiary care program that targets adult medical surgical patients discharged home. The goal is to keep the improved discharge and the follow-up process working long after the PA implementation ends. This explains why sustainable matters. A 30-day unplanned readmission often means the transition from hospital to home did not go smoothly. So currently, project set baseline is 18%, and readmissions add harm, stress, cost, and repeat workload. And systemically means the new process becomes routine standard work at the project site. This program focuses on adult medical surgical patients discharged home, especially those with higher risk of readmission. The intervention is an interdisciplinary social care bundle. The bundle includes 5 core steps that we can standardize and measure. SMART means specific, measurable, achievable, relevant, and time-bound. The first goal is an outcome goal, then we have a process goal, and we have a follow-up goal, and we have a balancing goal. Sustainable requires a small set of measures that tell us 2 things. Is the program still being done, and is it still helping patients? Our primary outcome measure is the 30-day unplanned readmission rate. This is the main result we wanted to prove. Our primary analysis measure is the mental completion rate. The secondary process is 48-hour contact completion. The balancing is 30-day emergency department visit rate. This slide explains how we will collect and monitor data without creating excessive burden. The quality analyst will pull monthly data from the electronic health record and available claims report. We will validate definition spot check a small sample so we can trust the numbers. Threshold prevent slow drift. We will not wait until the problem becomes large. For the primary outcome, we trigger an evaluation if the monthly 30-day admission rate rises above the baseline of 18% or above, the goal of 14% for 2 consecutive months. And the primary process, we trigger if bundle completion falls below 80% on 2 checks. For early contact, we trigger if the 48-hour contact measure falls below 75% for 2 weeks. And the balancing measure, we trigger if the 30-day emergency department visit rate rises by at least 2 percentage points above baseline, or if the monthly staff burden rating rises above 3.5 on a 1 to 5 scale. Sustainability depends on clear ownership. This is the sponsor, the chief nursing officer, who provides visibility, removes major barriers, and orchestrates resources or policy changes when needed. The unit level process owner is the adult medical surgical nurse manager. This role ensures the bundle is carried out daily, reinforces expectations, and holds the team accountable. The day 3, the social care nurse. The measurement is quality analysis. The training is nurse education and unit champions. And the cadence is the monthly dashboard meeting and quarterly leadership briefing. Communication should be simple, consistent, and built into existing routines. We will share what staff needs to know, what they need to know, and in a way that fits the clinical day. Training is what makes the process reliable across shift and across staff turnover. We will start with a briefing service that demonstrates the bundle workflow and shows staff exactly where documentation happens in the EHR. We will also practice teach back as a skill because it improves understanding and gives patient and families a clear voice in the plan. The tools that support staff include discharge checklists, plain language and language education materials, a 48-hour call script, and a simple escalation pathway for symptoms, medical issues, or social needs. To keep improvements from fading, we will follow a change management approach. Our sustained plan uses Carter's 8-step model, which focuses on building support, removing barriers, and anchoring change into culture. We will create agency by sharing baseline rate mission data and real examples of discharge gaps that lead to avoidable returns. We build a coalition by involving nursing, case management, pharmacy, providers, and outpatient partners in the sustainment meeting. And we will keep this vision simple. We flat research workload because improvements that increase burden are hard to sustain. In the short term, workload may rise moderately while staff learn the checklist and complete outreach steps. Over time, however, effective strategy will carry reduces discharge, relate problems, and avoid repeated admissions with lower rework. To keep workload manageable, we will use task shifting so each role does what it fits the scope. Nurses focus on feedback and confirm patient understanding. Case management support follow-up, scheduling resources. The transit lead owns the outreach forecast. We will automate where possible, such as creating follow-up tasks and using documentation templates. We will also use tiered intensity, so the full bundle is prioritized for high-risk patients. Finally, we will track a monthly burden pearls. If burden rises, we will adjust quickly, either by streamlining how work is done or by requesting protective time for a transition role. And these are all the references used in creating sustainable work.